Hello, and welcome to the University of Alberta Child and Adolescent Psychiatry Grand Rounds. I'm Dr. Alice Liang, and I will be your moderator today. We're very grateful to be partnered with the FOMD Office of Lifelong Learning, aka L3, which provides much of the logistical supports for these rounds. So, I'd like to do a territorial acknowledgement. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Nehiya, Cree, Niitsitapi, Blackfoot, Métis, Nakota, Stoney, Dene, Haudenosaunee, or Iroquois, and Anishinaabe, or Ojibwe Saulteaux lands that are now known as part of the Treaties 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So just a reminder, use the chat feature if you have questions directed to L3. And if you have a question for the speaker, use the Q&A feature of the webinar. And those of you who've been to our previous Q&As know that we now have the interactive option. So you can always put your hand up and we can unmute you so that you can ask your questions live. And you can also vote questions in the Q&A if you'd like. And I also wanted to let you know that Dr. Olga Winkler has kindly agreed to share her slides. So yeah, at this point, I'd like to introduce our speaker, Dr. Olga Winkler, who's a Canadian psychiatrist based in Edmonton here, where she runs a clinical practice and is the associate clinical professor at the University of Alberta. Her practice specializes in trauma-focused therapy for individuals with complex trauma, often stemming from childhood adversity, neglect, or abuse, with an emphasis on PTSD, borderline personality disorder, and dissociation. Her research explores innovative therapeutic approaches for these populations, including virtual reality-enhanced multimodal motion-assisted desensitization and reprocessing, or 3MDR, modified EMDR, and psychedelic-assisted therapy. We are delighted to have you present with us today.
Thank you so much, Alice. I'll get started right away. I'll share my screen first. If it's not okay on the other side, please let me know, but I think it should be good. Today we're going to talk about the intersection between dissociation and psychosis and some overlaps and differences. Some disclosures. Just of note, this presentation itself has not received any funding or in-kind support. However, I do have a number of grants that I've participated with as co-principal investigator, and those relationships are there. And I am part of a committee, psychedelics committee for CPSA. But other than that, there's nothing else to disclose. Okay, so what are we going to do today? Well, first define what dissociation actually is, a little bit about the etiology and the neurobiological foundations of what that reaction actually is. Then we'll spend a little bit of time comparing and contrasting psychotic and dissociative disorders. When I mean psychotic, I mean adult. I'm an adult psychiatrist, so I'll mostly present on adult presentations, but I do also have a couple slides on childhood presentations. Keep in mind, most of that was from my literature searches and not from clinical experience, but mostly from literature and also from what my adult patients have told me about their childhood experiences. And then we'll outline the treatment options for dissociative disorders to end with. Okay, so as you may be aware, in the DSM, these are the dissociative disorders on the left here that are outlined. Now, what they all really have in common is a certain degree of amnestic gaps or time gaps, certain degree of identity confusion and identity alteration, and some derealization, depersonalization. Most of them have some elements of that. And if you look at it from the perspective of what they actually have in common, you will probably like to start to begin to see that it's not just the dissociative disorders that this embodies. This embodies borderline personality disorder. This can embody PTSD, and especially the dissociative subtype. This can also embody certain mood disorders, and in fact, some anxiety disorders as well, especially panic disorder that's been in the literature. So it's more than just dissociative disorders that we're talking about, and we'll come back to that, what it actually means cross-diagnostic spectrum. Although in the DSM, we only identify the dissociative disorders, dissociation as a whole goes beyond just dissociative disorders, probably being present in every single diagnosis that we have. I quite like the DSM-5 definition of dissociation, which defines it as a disruption in the normal integration of these elements, which is consciousness, memory, identity, emotion, perception, behavior. Now, what this means is that we can actually have variable disruption in these domains in different people. So for some people, it will be just memory, such as dissociative amnesia. For some people, it might be emotion, such as alexithymia, and those are quite dissociative individuals. For some people, it's behavior and perception. Perception, it could be derealization. The world seems unreal or somehow different, and how it comes into the body, into our perception. And for some people, it might be even identity and behavior. The identity itself is fragmented, and the behavior shows differently depending on the different states that person's is in. So it can really range in terms of what it actually looks like, quite variably. It's very difficult to define as one single thing because it can be so variable, as you can probably see. Touching base a little bit on the etiology of pathological dissociation. So what I mean by pathological dissociation versus normal. Normal dissociation is, some people will say, being on autopilot, driving from my home to work on the weekend when I didn't pay too much attention. And then before I knew it, I was at work instead of the market. So gaps in time that people are aware of, but we all have absent-minded moments or absorption kind of moments, which is also a dissociative response, but it's not pathological enough to interfere with function or interfere with the overall work or relationships that we do day to day. So when I mean pathological dissociation, I mean dissociation gaps and intrusions that actually interfere with relationships or function. Those kind of reactions, the etiology of that, the most predominant theory out there is that it is due to trauma and or extreme stress. I actually quite don't like the word trauma response as a cause for dissociation, because trauma response is often associated with PTSD criteria A type trauma, the big T trauma, what we call big events or identifiable events. But in dissociation, so much of the extreme stress exposure has not actually been to big event trauma. A lot of it has been insidious, relational, extreme stress. And hence that leads me to the developmental model of dissociation, because most people with dissociative disorders can identify some kind of disorganized attachment or difficulty in attachment growing up. and it can be quite profound, that disorganized attachment and or difficulty in attaching. I'm including both because it's not just disorganized attachment that is an ideological theory of dissociation. It's also the caregiver that may be a wonderful caregiver for some other infant, but maybe not that particular infant with those particular needs. And that attachment misattunement can be a lot of the times enough to create dissociative responses as well. So it's a response to extreme stress rather than trauma per se. The parent may not have done anything traumatic. The caregivers may not have done anything traumatic, but the response in the person can still be that of extreme stress, and that can create a dissociative response. So it's really the extreme stress that matters, not the event itself. I want to mention some other ideological theories of pathological dissociation that have flown by over times, and especially the hypnotic model, because a lot of people will tell me that dissociation is really hypnosis. And there is some truth to, a grain of truth in that people that do dissociate tend to be more hypnotizable. But whether they have a dissociative disorder or not is a separate issue. So we actually call them double or single dissociators. Single meaning they just have a dissociation and not really a lot of propensity for hypnosis. But most people are actually double dissociators, to encompass that idea of, yes, they dissociate and they're very hypnotizable. The other things of note, there's been a model of dissociation to say that maybe epilepsy or epileptic activity or just some hemispheric laterality has something to do with dissociation. That has not been found to have any evidence in the literature. And the other theory is that maybe dissociative individuals are very suggestible. Maybe we can create dissociation or create these responses with even a therapeutic reaction or maybe some societal influence. Although we do know that that kind of influence can be and can have an impact in healthy individuals. In the clinical dissociative pathological dissociation world, there's no evidence that that contributes. So we do have some evidence that for healthy individuals, some are more suggestible, which again goes in line with that hypnotizability model and suggestibility model, but not once the pathological dissociation settles. It's quite a different thing. Now, this is just to show how we came to understand dissociation from a neurobiological perspective. What really brought dissociation to back in our attention, because it was quite prominently recognized maybe in the 1960s and prior to that, even starting with Janet. What really made it come back is this neurobiological or psychophysiology-based research. And Ruth Lanius, our colleague in Ontario, in London, Ontario, started it all with recognizing and doing studies on dissociative subtype PTSD versus non-dissociative subtype PTSD. And what she found is that in the dissociative subtype PTSD, there's a different reaction to trauma cues versus the non-dissociative. The typical PTSD that we know of, they actually have a reduced activity in the frontal cortex and reduced activity in the amygdala and cingulate, meaning that they can't think very well, and their amygdala is very highly stressed. Whereas in the dissociative PTSD, the opposite response is found, meaning that there's increased frontal cortex activity, the thought is there, and the executive function may still be active, whereas the amygdala is actually shut off. So dissociative individuals don't feel stress. That's really the highlight here. They don't feel as much stress when they dissociate. When they don't dissociate and they feel stress, that's another issue because they can fluctuate between complete shutdown and on and off, shutdown and activity. Now, well, the reason why this research is important is because when we look at research for multiple personality disorder, former or DID as it is known now, dissociative identity disorder, we see a similar pattern of activation in the brain, meaning the states that are subjectively experiencing the traumatic memory act like the typical PTSD. So the activation of the amygdala and the reduction in the frontal cortex, whereas the opposite is similar in dissociative PTSD. So we can see similar brain patterns depending on what state the person's in. If the person's experiencing trauma versus the parent is not experiencing a trauma memory at the moment, and they're just going about the regular life in a semi-amnestic state for the trauma reminders. Now, the other controversy that I just want to touch base on is this question of, is DID or dissociative identity disorder actually a thing? Is this not due to fantasy or maybe just acting? And Simone Rangers, who's probably the main author in most of these neurobiological research studies, she actually did a number of studies on this to prove that regardless of the fantasy proneness and role enactment, this DID is still present in the brain. Just like we looked at the PTSD studies before, we can see the similar kind of activation, deactivation in the brain. And that's regardless of whether somebody's fantasy prone or is acting or not acting. So there's something different about a dissociative brain that cannot be accounted for by just role-playing or fictitious disorders or being in a fantasy world. Now let's go on and talk a little bit about dissociative symptoms. I like this picture in particular because many of my patients will say it looks like I'm observing myself from behind my eyes. That's a very, very common complaint. So there's many different models of how we look at different dissociative symptoms. They're very difficult to categorize and just tell you a list of what they are, because people will describe them in so many different ways. And there's probably one of the best screens for dissociative disorders. The MID has probably 120 or 140 questions, if I remember more or less. So the symptoms are, and that's not even, that's even been shown that doesn't encompass all the symptoms either. So there's many symptoms of dissociation. So it's easier to actually look at the overall model of how we can categorize the symptoms rather than at the symptoms themselves at face value. Because if we can understand the model, we can extrapolate from the model to really fit with what the person's experiencing, describing, because it can be described in so many different ways. I like this model in particular, which is the 3D model. I'm not sure why it's called the 3D and not 4D, quite frankly, but they called it 3D model. But essentially what it is a degree of separation from 4 dimensions, which is time, thought, body, and emotion. At the bottom, we can see the normal, not pathological reactions. So if we think about time, for example, we can think of intrusive recall, such as in a memory that just keeps coming back. This could be, for example, a bad breakup, and we tend to obsessively think about it over and over. Again, it's not a flashback, it's just an intrusive memory, and maybe with some distress as well with it, right? So in other words, it's an intrusion of a memory on our time of normal activity. So a memory that intrudes upon our awareness despite our not wanting to think about it anymore. Now, this can be, again, a normal memory and normal stress reaction to pathological, which we think of in dissociative PTSD or even PTSD proper with flashbacks. So flashbacks, which is literally feeling like you're zoomed back in time and you're consumed by the emotions or the sensations by that memory, or even with some hallucinations. So that could be a flashback type PTSD reaction to sounds intruding, and breaking us away from time. So the time dissociation is more about time gaps, losing time. So this can be, again, losing time because the intrusive memories are so intrusive, and we're spending time on the past memories, not realizing how much time is going by, or losing time because something else intruded upon our awareness, such as a flashback, and we actually lost time, meaning we look at the clock, and before we look at it again, it's 5 minutes or 10 minutes after, and we have no idea where we were during that 5 or 10 minutes. Then we have the dissociation from thought. So on the normal spectrum, we have negative thought about ourselves, or negative self, or other referential thinking. And then the more we separate from our thought, it becomes a voice hearing thing, meaning that we can start to think the voice, the thought feels like it's a thought, but maybe it's not. The dissociative individual starts to question, maybe it's a thought that I don't want, but maybe it's a thought of somebody else. And we start to think, the dissociative individual starts to question and be curious, or even distressed about it sometimes, to the point where sometimes when the dissociation is very, very prominent, it becomes its own entity. So its own voice, or its own, it's not necessarily a voice sometimes, it's an own entity that has this thought. Depersonalization can go from normal experiences of just pure hyperarousal or panic attacks, or sensations. So when we talk about the body dissociation, we talk about sensations that intrude upon our awareness or we're not aware of. So could be hyperarousal, or could be lack of emotion, for sometimes kind of a little bit of numbing. This can be very common in grief responses, right? A little bit of numbing after losing somebody we love, or maybe hyperarousal when we've just gone through something very, very stressful, and we're a little bit on edge for a couple of days. That could be a normal response to stress. To very, very severe separation from body. And again, dissociation is about intrusion or lack of, it's about those sensations intruding upon awareness or not being accessible, meaning that the sensation can be intrude upon awareness, as in conversion disorders, somatic symptoms that show themselves as an emotional reaction, but we don't have access to the emotion, or it can show itself as a depersonalization, meaning the body itself floats out, looking from behind the eyes. And sometimes people will say to me, I feel like I'm in a taxi, somebody else is driving, but I don't have the wheel. Or some people will say, I feel like I'm in a trunk of a taxi. I have no idea where I'm going. I know I'm driving, but I don't know what's going on and I can't see it. So that would be more depersonalization, where a switch may happen. And intrusive bodily responses at that hypervigilance and conversion symptoms and other somatic reactions. And then we have dissociation from emotion, which at the normal spectrum is just general negative affect we all endure, to the high end of the spectrum, where an emotion intrudes upon awareness that feels like it may be mine, but it may be not, to an emotion that feels like it's completely alien to me. This somebody from somewhere else is inserting that emotion into me and it's not mine, to lacking emotion altogether, meaning being completely numb and blunt in emotion. So if you look at these 4 dimensions, you can see that as we separate more from these dimensions, these dimensions can either intrude upon our awareness or be not accessible to our awareness. This is another way to look at dissociation, which is more along the diagnostic spectrum. At the far end of the spectrum on the left, we have PTSD, mood anxiety disorders, and you can see some dissociative symptoms can be present, some intrusive symptoms can be present, so the flashbacks or maybe moods or maybe intrusive emotions or intrusive thoughts. Then we have the dissociative PTSD, which is a little bit more. Then we start to have depersonalization, derealization, maybe some identity disturbance already in the dissociative spectrum. And then we have the complex PTSD borderline spectrum, which we have all four, but not yet discrete identity states, which start to begin probably in some dissociative disorders, in somatization and dissociative identity. Now, where does psychosis fit in with all that? Moskowitz, which is one of the main authors on psychosis, the intersection of psychosis and dissociation, talks about this, and he puts dissociative responses and psychotic responses and how they merge at the full end of the dissociative identity disorder, meaning that in dissociative identity, we have actually separate personalities and separate identities that are somewhat encompassed within one another. Whereas with psychotic disorders, there's no apparent personality. There's a loss of their identity or sub-identity, and then it starts to merge into other psychotic symptoms. That's just a theory of how it progresses. In other words, to say that the psychotic symptoms can also be viewed as the severe extreme of dissociation, where it no longer has an identity. So let's go through some dissociative and psychotic disorders and take a look at the distinctions and overlaps between them. The first thing I want to point to is the common risk factors. One of the things that I think will be most pertinent to child psychiatry is the disorganized attachment. And this is a specific kind of disorganized attachment where the caregiver is both a source of solution and stress for the infant. And it's usually, I say the infant because most of the most severe dissociative disorders really happen with the disorganized attachment and the misattunement injury really happened very, very early, probably pre-verbally, meaning prior to the age of 3, definitely prior to the age of 6. So when the caregiver is both a source of solution and stress, and when there's some gaslighting, meaning your reaction wasn't real, it didn't happen, that's a huge risk factor for developing dissociative identity and or dissociative psychotic symptoms later on. Essentially, it's a relational trap, a fright without a solution. The child is trapped in a relationship with a caregiver who sustains it for food, for caregiving, for all the sustenance of life, but cannot escape at the same time. And that trap is thought to trigger dissociative responses because that's the only escape there is. Now, the other common risk factors, so these common risk factors have been found both in schizophrenia and dissociative identity disorder, all of them. As again, I notice that it's before and after birth and preverbal infancy. I say before and after birth, and this might sound strange, but there's different theories about how that happens. One predominant theory is if there's a relational difficulty in the parents or the child was unwanted, that kind of relationship gets carried on into the infantile stage, and the expectations for the child are different. And again, that creates that attachment where maybe the mother wants to bond but can't, and the child or the infant might be confused in terms of how the body responses and the facial responses of the mother or the parent look like on the mother in what they say and what they do. It just doesn't quite, isn't quite aligned, and that can cause that fracture. There is quite significant sexual physical abuse in both schizophrenia and dissociative disorders, but In dissociative identity disorder, the sexual physical abuse is much, much higher than dissociative disorders as a baseline. They also have both schizophrenic, psychotic, and dissociative disorders have problems with affect regulation, mentalization, and episodic memory. So some similarities there. Interesting enough, the structural and functional brain changes. There's volume loss in these areas. I mean, it's something that we see across all mental disorders, really. But the altered functional connectivity is actually more interesting because it's the key areas that are involved in regulating affect, memory, introspection, saliency detection, and integration of new stimuli, including self-consciousness of behavior and agency. All the things that are really highly affected in dissociative individuals, these are the areas that are involved, and these are the areas, especially the insula and the anterior cingulate, really highlighting that the integration of all these and the growth potential of development potential of all these areas in how the child brain develops in being able to regulate affect, to be able to look inside and feel and reflect on one's own emotions and feelings and experience in order to detect threat or detect and say to oneself, this is real. I'm not just pretending, or not, my body's responding to something and it's real. The saliency detection is off in dissociative individuals. They can't really tell what is real danger, what is not. And the integration of new stimuli, again, how that stimuli comes in, how the world comes in is distorted in dissociative individuals. They can't really tell what is real, what is not sometimes. And they're not aware or consciously making decisions with their prefrontal cortex all the time because it goes on and off. And they have a different sense of agency, meaning in dissociative individuals, I'm not able to make decisions on my own. There's somebody else making decisions for me, or my body is making these reactions for me and I can't control it. So the sense of agency is very off as well. Now, key differences really came through with personality cognitive testing with schizophrenia and dissociative disorders. Now, there are some differences, especially in verbal and delayed memory and scores on ways, which are prominent in psychotic disorders, but not in dissociative disorders. Obviously, the trauma symptom inventory, because dissociative disorders are more related to trauma than schizophrenia for most part. The trauma symptoms inventory is usually higher in dissociative disorders. And interesting is the projective testing. Dissociative disorders individuals tend to be more logical and rational and more relationally attuned. They also don't oversimplify their experience. They're actually really complex thinkers, probably more complex than most normal individuals. And they have greater collaborative engagement in those tests. They're able to reflect a little bit on their inner experience when they're allowed the space and feel safe doing so. And they have an interest in others. Whereas schizophrenia, as we know, those negative symptoms can really, really interfere with that. So what about psychotic symptoms in dissociative disorders? So this is more of how much is psychosis and how much is dissociation. When we look at, when I was in resident, when we look at first rank symptoms of schizophrenia, especially hallucinations, there's been a number of studies, especially recently in the last 5 years, that have indicated that hallucinations on their own are actually much more indicative of dissociative disorders than psychotic disorders. And a lot of the first rank symptoms are actually more indicative to dissociative disorders. So it's actually not the presence of positive symptoms that's indicative of primary psychotic disorders. it's the presence of negative symptoms that is more indicative of a primary psychotic disorder. Again, this aligns with the psychological testing that we saw beforehand as well, right? So the people with more negative symptoms and positive symptoms are more likely to have psychotic symptoms than the people with just positive symptoms. So just to, again, emphasize this point, the Schneiderian symptoms, I wrote them out because I don't work very much with schizophrenia, I'm more for myself. But these are the Schneiderian first rank symptoms, just for your reference. When we look at dissociative disorders, we see that the first rank symptoms, the Schneiderian symptoms, are very, very predictive of dissociative disorders, much more than any other psychiatric disorder. Which goes along with what we see in DID patients, especially dissociative identity patients. About 90% of them will report 3 or more Schneiderian symptoms. And when we think about it, really, the prevalence of dissociative disorders in the general population is anywhere between 12 to 18%. In the psychiatric patient population, it can be up to 40 or 50%. In the inpatient population, it's up to 50%. Now, this is interesting. This is based on studies done in inpatient populations. It's interesting to note because most of us don't diagnose dissociative disorders in the inpatient population. I barely see a dissociative disorder as a diagnosis, yet studies show repeatedly that they're extremely prevalent in our inpatient population, psychiatric population. So considering that the dissociative disorders are so much more prevalent than psychotic disorders, psychotic disorders being 2% maybe in the general population, right? Considering that they're so much more prevalent, it would make more sense that, and considering that hallucinations, especially auditory hallucinations and positive symptoms, are so much more prevalent in dissociative disorders, it would make sense that when we see hallucinations, when we see positive symptoms, we should be actually thinking more about dissociative disorders first than a psychotic disorder. Now, dissociative identity rarely experience thought diffusion, projection, or delusional perception. So delusional perception, delusions are not so indicative of dissociation as are hallucinations. I'll talk more about this later here as well. I'll break it down a little bit more for you all, what this is. So when it comes to hallucinations in particular, voices in dissociative disorders usually appear before age 18. Usually there's 2 or more, and usually include child and adult voices. They're also more likely to be perceived as angry, persecutory, or commenting because the person is splitting off the worst of the abuse or attachment hurt from their prominent self, meaning that the things that intrude upon awareness, the traumatic or stressful intrusions, would be the ones that the person wants to reject the most, meaning the angry, the persecutory, the commenting, the threatening voices. The other thing that's really notable is that with dissociative hallucinations, we can actually engage in conversation with them. With the psychotic schizophrenic with positive and negative symptoms on board, we can not engage in conversation. People will report on the voices, but they will not necessarily, if we ask them, what does the voice say if I ask this? Or how does the voice respond when I ask and fill in the blank? The patient with psychosis will likely look blankly at me and say, well, they just say this, I don't know what you mean. Whereas this dissociative individual will actually engage in a conversation with the therapist. Visual hallucinations tend to be more elementary in nature, such as light. So they're more like light. They're more perceptual, illusion type experiences, change in shape of objects, objects are being closer or further than they are. But they actually can be a dramatic person, an animal, or an unidentified creature, which again is pertinent for child psychiatry, with imaginary with friends, right? Imaginary friends in childhood. I'll talk a little bit about that later as well, more specifically. They may be visual companions. And the other thing, hallucination that can happen is sounds. So intrusions of sound, which is more screams, tastes, is intrusions of hostile sounds or screams. It can also intrusive sensations, body sensations, or pain that may present as well. Disorganized thought and behavior is not the kind of thought and behavior, disorganized thought behavior that we see in schizophrenia, because in schizophrenia, it's more persistent. It doesn't switch from disorganized to normal. When we think about disorganized thought and behavior in dissociative disorders, it's usually as a result of switching identities or flashbacks of some sorts, or breakdown dissociative barriers. So the behavior is on and off, and the thought disorder is not an actual thought disorder. It's just how it presents. It mimics thought blocking or thought withdrawal. And again, the reason for it is usually switching alters or intra-interview amnesia. So the reason for it is different. It's not an actual thought disorder. It's because there's switches in the brain and how the brain interconnects different alters, and how it can connect to time, that presents these symptoms, and they can mimic disorganized behavior and thought disorder, but they're not actual disorganized behavior and thought. Impairment in reality testing is thought of more as a trance rather than a delusion. So whereas the psychotic person will have fixed false beliefs and delusional thoughts, the impairment reality testing in dissociative disorder is more like a trance. So living in an altered reality, like a different kind of feeling of being in a different world, or the world feels somehow different, and therefore the explanation for why that world feels different can sound like it's delusional. But again, it's more about history taking to actually recognize, what does the reality look like? What does the table feel like? Does it feel real? Does it feel not? Does the light look real? Does it not? Does the floor shift? Does it not? Why do you think that that you're living in a matrix, for example, right now? Is it that you actually believe that this is a matrix, or is it something about this world doesn't feel real, that it is a matrix? And what is not real? Is the light not real? Does my face look different or distorted? So what about this world feels different to you, that you interpreted it as something different and interpreted it as a delusion? Now let's talk about the dissociative symptoms in children and how it can present. Now in preschool children, their sense of self is not yet formed. So we have transitional internal identities. They're called transitional internal identities in the dissociative literature, whereas voices or internal identities are actually projections of the self onto something, usually internally, and they attribute special characteristics or develop relationships with that. So this is more like a voice, an internal voice inside a child, that they can internally communicate with, talk back to, and it feels like a conversation with someone. Now, they're different from imaginary friends, that sometimes later on it actually develops into an imaginary friend. And the difference from a transitional identity and an imaginary friend is that often these identities, whether internal or external, later on in childhood become external. They're linked to some kind of stressful or traumatic event, usually linked to fear, anger, or internalization of abuser characters. They're not happy. They're not usually friendly either. So when there's a non-friendly identity, whether internal voice or external imaginary friend, and there's some kind of attachment misattunement or physical sexual abuse or trauma in a child, I would be more leaned towards a dissociative reaction rather than a psychotic reaction. And oftentimes these identities, they at some point, maybe not at the point of the interview, but some point in life, they become independent enough for the child to feel like they're doing something against their will. So the voice is saying something that's ego dystonic, or the imaginary character is doing something that the child doesn't really like and knows is wrong. And often will start to come with amnesia for actions of the child during these episodes as well at some point. Now, behavioral signs of a preschool child, usually a trance-like state with reenactment, staring into space and playing on their own, reenacting something, non-communicable. This isn't prolonged. This can be, usually people will say to me, well, I can't really see it. It doesn't really happen. But when I talk to patients, it's really a split second of the reenactment, and then the person is normal, and then another split second, and the person's normal. So it can be quite difficult to catch, and a lot of the times it needs to be identified on history taking, not observation. And then when you do the history taking and you listen to patients actually say, well, yeah, I went through an amnestic gap, or I knew that I was kind of on autopilot and just doing things, but my hands weren't doing it. It was something else that was controlling me. Then you can start to look for it in behavior, and then you can start to see it, because it can be quite difficult to catch. And then there's also dysregulation overall. There's amnesia and confusion that can come as well, but also tantrums, sleep disturbance, nightmares, insomnia, almost PTSD-like nightmares, but for traumatic themes or stress-induced themes or attachment themes. There's also quite a number of psychosomatic symptoms in children. If a child is experiencing a non-medically explained headaches, stomachs, body pain, with a history of attachment injury, with a history of trauma, abuse, I would be thinking more of a dissociative reaction there as well. Interesting enough, unfortunately, in North America with our DSM, conversion disorders and trauma disorders are separate, but actually in the ICD, somatic disorders and somatization reactions are very well recognized as a dissociative disorder, a dissociative response. They don't separate the two. And working with dissociative individuals now, I fully agree with that description. The somatic responses that are not explained medically in the context of adversity, trauma, attachment injury, and all the things that we've talked about, oftentimes is related to some kind of extreme stress response. And there's other unpredictable behavior, regressive behavior that may be hard to detect unless observed. School age. With school age, we start to see more of that identity projection onto toys and stuffed animals. And again, things you might be looking for there is more of that, the emotions that are around fear, anger, the difficult emotions that might be difficult for the child to integrate, more abusive projections, and agency, lack of agency over what that toy can do. So the child says, no, this toy is doing things on its own, and I'm afraid of it, and they have all the history of abuse or adversity, memory gaps, memory. So it's more of a complex of symptoms rather than one single thing. You have to look at the whole picture there. Cognitive fluctuations, very common. Intelligent tests change so much with dissociative individuals. I remember one DID patient who tested IQ 80 one day, and then she was 130 the next day, and she was labeled as factitious and just not wanting to do the test, but actually dissociative barriers she presented us in different states on different dates. And cognitive fluctuations in school can impact schooling as well, and children can be affected by this as well, and they can be interpreted as not trying hard enough, being avoidant or willful. They start to have amnestic episodes, and they will start to tell us that they feel like not themselves, especially when they're very angry, very upset. And memory gaps happen especially when they're very, very dysregulated. And trance-like states become more common as well. And the post-sleep behavior may be aggressive, or regress behavior can happen as well, usually as a result of nightmares that have triggered something. whether they remember them or not. Adolescence is when we start to see dissociative disorder in the full spectrum and how it actually looks in adulthood. So I'm not going to go through this because what you see in the adult literature, you will see in adolescence as well. And like I said before, most dissociative disorders will present themselves prior to the age of 18 in adolescence at some point. These symptoms will show up if you look for them. Very quickly on treatment, unfortunately, we have nothing in our literature to say there's consistent evidence for any kind of pharmacotherapy. But considering that dissociation is thought of as a severe stress response or a trauma response, our goal is really affect stabilization. And I say affect, not mood, because dissociated individuals will not feel stressed, just like we talked about in those scans of dissociative PTSD, right? Their amygdala may not be active during dissociation. They might not feel stressed, but that doesn't mean that their system is not stressed as a whole. So our medication strategies should be around, or have usually been traditionally around, affect stabilization, whether that's with antidepressants when there's more of an anxious kind of presentation, or mood stabilizers if there's more fluctuations in mood, or if we have to go to neuromodulation, TMS, or even ECT. The goal behind that has always been just to stabilize affect underlying the dissociative symptoms. And then we have the PTSD-informed treatment as well, because a lot of the literature in dissociative disorders will theorize that dissociative disorders really are an extension of PTSD. We just haven't recognized them as such. So prazosin for nightmare, for example, is one treatment that's quite common for dissociative disorders when they have significant nightmares. But really, the main treatment in dissociative disorders is, and always has been, psychotherapy. And stage 1 is usually the longest of this treatment. And the main ingredient in any kind of successful treatment for dissociation is long-term, consistent, trusting relationship with a provider. Psychoeducation alone about what dissociation is and how it can present, and that it is a stress response, whether it feels like one or not, can be profoundly helpful for people so they don't feel crazy and shamed about their very strange reactions, which they know they have enough insight to know that they're strange reactions, so they don't tend to share what they are with a lot of people, even providers, because they think they're going to be labeled as crazy, hospitalized, and put on very, very strong medications. So they're very skittish about presenting all their symptoms to you. And at the first meeting, usually it takes multiple meetings over time to really understand and recognize all the symptoms. Coping skills are very helpful to regulate, again, that dysregulation, that affect dysregulation, whether it feels like it or not, it's there, because the dissociative barriers, again, might make it not feel stressful. So some people will say, well, I don't need coping skills because I don't feel like I'm that dysregulated, really. Some people are over-regulated. In other words, some people think so much that they over-regulated with their thinking and they dissociate as a result. So their coping skills might actually be to increase their emotional awareness, increase their emotion rather than decrease emotion. So coping skills, including CBT, DBT-informed skills, or even cognitive processing therapy with a trauma therapy, can be helpful. It works at the prefrontal cortex and helps with that downregulation of the amygdala and the deeper layers limbic system that can be overreactive when the dissociation is not present. And trauma processing is the stage 2, but it should be used extremely cautiously, because working with dissociative individuals, when used too soon, too quick, it can break through those barriers and cause more of a problem. I've certainly seen people admitted for psychosis after a trauma therapy, because the dissociative barriers were broken through too quick, too fast. So it can create really severe suicidal crisis and hallucinations, and those voices coming on stronger. Many therapists will say that inner-directed altered state therapies are actually much more gentle. So hypnosis or ego state, internal family system, somatic therapies, deep brain reorienting. There's a lot of different therapies. None of them are evidence-based for anything yet. But a lot of therapists will use them wisely, because the trauma-focused therapies that are evidence-based are just too fast, too strong, and there's just too much of a risk with them. So these inner-directed are much slower, gradually working with the dissociative barriers. So take-home points. I think my main point today is that the Schneiderian first-rank symptoms are more indicative of severe dissociative disorders rather than primary schizophrenia or psychotic disorders. And it's actually the presence of negative symptoms along with the positive that's more indicative of psychosis. Really, a lot of similarities between psychosis, psychotic and dissociative disorders in the trauma attachment histories and brain changes. Really is telling of this link between the early development, life development, and severe disorganization on how the brain connects later on in life. But there is a difference in cognitive tests and relational attunement and insight in psychosis versus dissociative disorders. For this child psychiatry population here, the dissociative symptoms usually present before age 18, and adolescents are more typically present as dissociative disorders, whereas children have those transitional identities, and it's usually behavioral and emotional. So with that, I have probably a couple minutes for questions. These are my references.
Thank you very much, and for this very richly informative and thought-provoking, presentation. Before we go to the Q&A, just a reminder for people that these rounds are certified by the Royal College of Physicians and Surgeons of Canada and also the College of Family Physicians of Canada. So, and we are trying to get better at sending out the CME certificates sooner rather than later after these attendance at live rounds. And some of you might leave a bit earlier, although we will have Q&A till 12:15 if there are questions. And so if you are leaving earlier, this is the QR code to scan and to do the evaluation. Just as a reminder that the Grand Rounds Committee does take a look at all of the evaluations and really use it to inform our processes and future rounds topics. And one example is just us trying to increase the interactivity.
I see one question already, Alice, if I could address that.
Yeah. So we're going to go to the Q&A. I'm just reminding
perfect.
the evaluation. So yeah, let's go to the Q&A here. So Dr. Brent Harold is asking, can dissociative identity disorder be better explained as an iatrogenic disorder that is better explained by PTSD, cluster B, personality disorder, and schizophrenia?
Right. So I think what this question, if I could understand it correctly, is getting at, can't dissociative disorder be more in line with how PTSD and cluster B and schizophrenia present? I absolutely agree with that. So I've seen a lot of literature that argues, and even with the development of the DSM-5, there was this huge argument of what is trauma, PTSD and trauma as stress-related disorders. There was a big debate whether cluster B should be included as a trauma disorder. There wasn't a debate about dissociative disorders, but dissociative disorders were strategically placed right after stress disorders. And I was speaking with some of the people that were involved in those committees and how they decided that, which was interesting because they said that the North America is not yet ready for seeing dissociative disorders or personality disorders as trauma-related disorders. Therefore, we need to keep it separately, but we want to recognize the relationship between them, that it really is a spectrum. It's not one or the other. It's not a clear-cut line between them. And Dissociative identity disorder, for all it's worth, it presents very differently at face value at a 45-minute interview. So when we see people for the first time, when we only have one consult, it's easier to diagnose a DID versus DID as part of PTSD or cluster B or schizophrenia. It's easier to do that. The relationship to trauma and attachment and all the other symptoms of cluster B, PTSD, and schizophrenia usually come out later over time. So it's not as easy to diagnose at a 45-minute interview, which maybe that's why it was separated more for practical reasons. What is the relationship between night terrors and dissociative disorder? That's a great question. I don't know the literature on this. I haven't looked into that. But speaking with my dissociative identity patients over time, almost all of them had night terrors. And when I ask them what the night terrors were about, it's usually similar themes: being chased, being trapped, there's no way escape, which again goes back to what I spoke about in the presentation. Dissociation is really an escape strategy for an inescapable situation. So when the dreams are more in line with, I can't escape, I'm trapped and I'm being hurt, but I have to stay, but I have to escape. If those themes are there, I would start to wonder whether there is some relationship with dissociative disorder. And I would ask dissociative disorder questions to follow up, and those attachment questions and the physical sexual abuse screens and all that, right? So it's more of a clue that there could be something for me, but I haven't seen them completely tied in the literature, but I also haven't looked at that literature either, so I don't know. Another question: if emotional regulation are so important for those with high rank symptoms, how can we address the barriers? What a beautiful question. And I have this discussion with my adult colleagues all the time, because I've had so many patients, I've seen so many patients be diagnosed with schizoaffective disorder that are actually dissociative disorders. And I've had many patients with treatment-resistant schizophrenia that are actually dissociative disorders. They've had one psychotic break and nothing since then, and they've taken themselves off antipsychotics, and they've been, with therapy, they've been doing much better than they have been without. So there is something to that, but also the fact that when we put those psychotic disorders on a diagnostic exam and on our files, it really follows the patient all their life. And they can be excluded from group therapies, and usually the CBT, DBT coping skills are offered in group therapy. They can be excluded on past history of psychosis or risk of psychosis, and it's really unfortunate because they can be so very, very regulating. And quite frankly, even for some schizophrenia patients, they can be so helpful. So it's really unfortunate, and I agree that emotion regulation skills are should be really more available to people with a history of psychosis. Are there any genetic markers that predict dissociative disorder risk? No, there are no genetic markers, but epigenetics and the PTSD trauma, stress and trauma research has shown DNA methylation and telomere length has linked that to a variable stress response and cortisol response. So we know, in other words, that how we respond to stress, meaning how much cortisol we produce, is actually can be epigenetically transmitted. But again, it's epigenetics, meaning the genes still have to have the right environment to be turned on to have that cortisol response. So it's not so clear as to say there's a gene and it gets transmitted. It's the epigenetic transmission of a potential for propensity for a stress response that's higher. And when there's a stress response that's higher, there's dissociative responses that are present, because that just goes hand in hand. So it hasn't been looked at directly, but a lot of experts in the field will tell you that, yes, absolutely, that happens, yes.
And I actually have a question. Thank you for answering all of these, questions. I have a question as well in terms of, I was really intrigued by your, comment that, IQ can actually be variable for
Yes,
these individuals who
yes,
are on the dissociative traumatized spectrum, because there's been a couple of youth I've seen that um, they actually test and they present as like very slow processing speed,
yeah,
post trauma. And in one case, because I've seen this kid long enough, they actually like speeded up, significantly, after, they were, doing therapeutic work for a while. And I was wondering, do you, see this as well in terms of, especially for, like processing speed and, some of this, yeah, that they just can't think
yes,
properly or very
absolutely.
well. Yeah.
Absolutely. I think the processing speed, so processing speed is more of a gross evaluation of what happens in the brain, right? So when it actually, when the dissociative barriers come on board, it could be due to a multitude of factors. It could be mini amnestic gaps. It could be that dissociative derealization fog, right? Where you can't focus on the text and then the text seems blurry, or just just a second of that is enough to throw the brain off into a foggy type of concentration and thinking. I don't even know how to describe it. It's just the brain is slow to think. Because after a dissociative reaction, it's not like, unless you're actually a DID patient and switch back and forth very quick, most dissociative reactions are really profoundly difficult on the person. They're exhausting. So when the person comes out of dissociative reaction, it's not like, snap of the finger and I'm out and I'm back to my regular self. It takes a good hour or two, sometimes a couple of days for the brain to catch up. It feels foggy, it feels blurry, it feels slow. I can't think. It takes time. So I can absolutely see that happening. Absolutely. And I've seen that in my office multiple times. When people do dissociate, it does take them time. Sometimes word finding difficulties, not being able to say like what appears like thought blocking, like again, what appears like what mimics thought blocking, what mimics low processing speed. It's the mimicry, but the actual deficit is a little different, right? The actual, it's not
Yeah,
the
that makes
actual,
sense because with this, yeah, one particular youth, they actually fluctuated, like they generally like pretty slow at talking, but sometimes they were like incredibly slow, like to the point that there was like long pauses, and yet maybe like, a few days later, because I'm in residential treatment, so I get to see this, then they are, faster, even though they're still overall slow. So yeah, so that
yeah,
might be an indication that they actually have a dissociative response, like very, like I guess either currently or like
yeah.
recent.
So I have a question here or a comment. Remember that IQ testing should be 2-year gap between tests to be valid. And absolutely, in individuals that are not dissociative identity disorder, I can see that. But when you have a dissociative identity disorder, it's almost like you're doing IQ tests on 2 or 3 or 5 different people. So it's different. Depending on the day, you may have a different state present and therefore a completely different IQ. So it is different in DID patients. I don't know if that would be that we could say that it should be a 2-year gap in DID specifically.
And is there literature on this? Like we could, I guess we could look it up, as that is, interesting in terms of, because that has implications, because if we test a traumatized kid, like a lot of these kids are kind of like lowish in IQ, and then, we sort of, I guess,
Yeah,
teach them as if like they are, or sometimes we even exclude them from our programs.
right.
Talking about emotion regulation groups, we also exclude them from our programs because, well, they're too low IQ. But maybe some of that, if it's related to trauma, we're actually excluding them from
Right.
actually receiving potentially
So,
helpful treatment, right?
right. So the history becomes very important and collateral becomes very important. I mean, do they behave or function differently in different settings? where they feel safer, right? Do they feel with different people? Have the parents notice that the person looks and feels like a different person in different circumstances? So we're screening for dissociative identity disorder at that point, right? If we're suspecting that. And then I would say absolutely have to take a look at that a little closer. Yeah. Okay.
Okay, I think that might be all the questions for now. So, yeah, again, lots of food for thought, and yeah, and we definitely really appreciate you taking the
Thank
time.
you so much for having me.